My dear students, in this video, I'm going to discuss some of the salient features pertaining to hepatopulmonary syndrome and portopulmonary hypertension. Let us start with this case. The case 1, a 52-year-old male with alcohol-related cirrhosis with child PUG-C classification presents with progressive dyspnea over a period of 6 months. He reports that breathlessness worsens on sitting or standing and improves when lying flat. On examination, saturation is 92% on supine while 84% on standing. Clubbing is present. Spider angiomas are noted on several parts of the body, including the chest. The lungs are clear with no signs of heart failure. The key features that are revealed during examination are dyspnea, which is out of proportion to the chest findings. There is platypnea and orthodeoxia, that is the worsening of breathlessness on sitting or standing and improvement on lying flat or supine, and also the characteristic presence of advanced liver disease. So the provisional diagnosis here that is made is hepatopulmonary syndrome. In ABG, the PaO2 shows 58 millimeter of mercury on room air. The alveolar arterial gradient is increased. So hypoxemia with widened alveolar arterial gradient suggests shunt or VQ mismatch. On doing contrast echocardiography or bubble study, there are microbubbles which appear in the left atrium in both the four-chambered view as well as other view, that is three-chambered view, after 4 to 5 cardiac cycles. And again, their delayed appearance is noted, which is indicative of intrapulmonary shunt. In technetium lung scan, there is uptake seen in brain and the kidneys, which confirms extrapulmonary shunting. So here, the final diagnosis is confirmed to be hepatopulmonary syndrome. Take the second case, a 45-year-old female with non-cirrhotic portal hypertension presents with progressive exertional dyspnea and repeated bouts of syncope. On examination, patient is having loud P2, raised jugular venous pressure, hepatomegaly and pedal edema, and the saturation is 96% on room air. The key features, distinguishing features, include dyspnea with syncope, signs of right heart failure, as well as normal oxygenation at rest. So the provisional diagnosis that is made here is portopulmonary hypertension. On doing further investigations, the 2D echocardiography shows dilated RV. The RVSP is around 60-65 millimeter mercury. There is intraventricular septal flattening, and all of this suggests pulmonary hypertension. On right heart catheterization, the mean pulmonary artery pressure is 38, the wedge pressure is 12, the PVR, pulmonary vascular resistance, is 5 Wood units. So this suggests pre-capillary pulmonary arterial hypertension, and therefore the final diagnosis is portopulmonary hypertension. So both these conditions are pulmonary vascular complications of chronic liver disease and portal hypertension, but they are pathological opposites and often tested together. So let us first come to the hepatopulmonary syndrome, which is by definition characterized by chronic liver disease or portal hypertension, along with intrapulmonary vascular dilatation and impaired oxygenation, which is indicated by an increased arterial to alveolar gradient with or without hypoxemia. The pathophysiology for this condition is because of excess nitric oxide and vasodilators, which dilates the common pulmonary capillaries. The blood flows too fast or too far from the alveoli, giving rise to diffusion-perfusion defect. And this results in right to left intrapulmonary shunting. The clinical features are platypnea, which is dyspnea, which is worse upright, orthodeoxia, that is the fall in PO2 on standing, which is the hallmark of this condition. There can be cyanosis, clubbing, spider nevi, and often there is no significant pulmonary hypertension. So the diagnosis is based on the ABG finding of raised alveolar to arterial gradient, contrast echocardiography or bubble study showing bubbles appearing in the left atrium after 3 to 6 cardiac cycles, and technetium scan showing extrapulmonary aortic uptake, particularly in the brain and the kidneys. The portopulmonary hypertension occurring in portal hypertension with or without cirrhosis. Here, the right heart catheterization is mandatory, and the hemodynamic criteria is an increase in the pulmonary artery pressure more than 20, pulmonary vascular resistance of more than equal to 2 Wood units. As you can remember that in our patient it was 5 Wood units, and the pulmonary capillary wedge pressure is less than equal to 15 millimeter of mercury. The pathophysiology here, in contrast to HPS, is pulmonary vasoconstriction plus vascular remodeling. So there is an increase in endothelin and a reduction in prostacyclin signaling. This leads to progressive right ventricular failure. So the clinical features manifested are exertional dyspnea, fatigue, along with syncope, signs of right heart failure. But one has to remember that there is no platypnea or orthodeoxia, which is noted in HPS. The diagnosis is based on echocardiography. Screening shows high RVSP, and right heart catheterization finally reveals the findings, which are mandatory for the diagnosis. Now, both these definitions are from the 7th World Symposium on Pulmonary Hypertension and the 2022 the European Society Guidelines, the joint guidelines of the Cardiology and the Respiratory Society. So if we looked into the differences in the pathophysiology, we find that in both conditions there is portal hypertension and cirrhosis. It may or may not be cirrhosis in the later, but in portal pulmonary hypertension, there is endothelial dysfunction which lies in increase in the ET1 with the fall in nitric oxide, fall in the prostacyclin with increased oxidative stress. Whereas in hepatopulmonary syndrome, there is increase in the iNOS or nitric oxide synthesis and increased nitric oxide, increased prostacyclin with increased cyclic GMP. So in portopulmonary hypertension, there is remodeling of the pulmonary arteries, there is medial hypertrophy, intimal fibrosis, further giving rise to increase in the PVR and the mean pulmonary artery pressure. Whereas in hepatopulmonary syndrome, there is diffuse capillary dilatation with intrapulmonary shunts and consequent VQ mismatch. So in portopulmonary hypertension, there is finally right heart failure, whereas in hepatopulmonary syndrome, there is hypoxemia and respiratory insufficiency. So the management also differs because in HPS, it is primarily supplemental oxygen, but the definitive treatment is liver transplantation. No effective medically proven therapy is there. In portopulmonary hypertension, there are the role of PAH specific therapy, pulmonary hypertension like the endothelin receptor antagonist, the PDE5 inhibitors, and the prostacyclin analogs. The liver transplantation is only indicated if PA pressures are adequately controlled, but in severe POPH, it is the liver transplantation is contraindicated. If you look the management of the decompensated state, we can find clearly the differences which are very evident. I have already discussed the differences in presentation and diagnosis. If you look into the oxygenation part, you can see that intubation can precipitate acute hypotension and cardiac arrest in POPH because it is minimize the lung volumes and the peak pressures, and these may increase the right ventricular afterload. So that is the cause of acute hypotension and cardiac arrest. Whereas oxygenation is the supplemental oxygenation is the mainstay of treatment in HPS, and in post liver transplant hypoxemia, maintaining SpO2 has to be prioritized. The fluid balance, of course, is typically negative in both POPH and HPS, but we have to optimize the right ventricular preload in POPH, and we have to avoid pulmonary congestion in HPS. If you look into the role of vasopressors again, you may please note that catecholamine vasopressors like norepinephrine or epinephrine followed by vasopressin, they become essential in POPH. In post-LT hypoxemia in HPS, Bacillary pulmonary vasoconstrictors like methylene blue may help in reducing the intrapulmonary shunting and improve hypoxemia. So the role of the vasopressors is there in both, but the vasopressors are not identical but distinct in the conditions. If you go into the extracorporeal life support, the VA ECMO is necessary for POPH, whereas it is the VV ECMO which is required in case of HPS. So these are the various differences, but one important point to note in terms of outcome, that post liver transplant PH mortality is known to be high, but precise estimates are not clear in POPH. But in post LT acute hypoxemia, mortality is more than 70% in HPS. So finally, my take-home message for these two conditions, which is important for every student to remember, is that the course comes in the courses, the condition courses from the same liver disease, but with opposite pulmonary problems. In HBS, it is the pulmonary vasodilatation, which leads to hypoxemia. In POPH, it is the pulmonary vasoconstriction, which produces RV failure. Platypnea, the orthodeoxia is the divider. If it is present, you have to think of HPS. If it is absent, you think of POPH. Oxygen saturation guides our suspicion. If it is low SpO2 with clear lungs, then that is an indicator towards HPS. Normal SpO2 with severe dyspnea indicative of POPH. Echocardiography answers the different questions. For HPS, contrast echo shows delayed bubbles because of intrapulmonary shunt. In POPH, echo is only screening. Diagnosis requires right heart catheterization. Right heart catheterization is mandatory in POPH, and it is required before leveling POH and also required before liver transplant listing, because severe POPH is contraindication for liver transplant, as I mentioned before. This liver transplantation also has opposite implications, because in HPS it is curative regardless of hypoxemia severity, whereas in POPH it is conditional, that severe disease is a contraindication. The medical therapy also differs completely. In HPS, there is no proven disease modifying drugs. Oxygen is supportive. In POPH, they require PH specific therapy, including PDE5 inhibitors, endothelin antagonists, and prostacyclins. Thank you.